Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, the Medicare program. Dr. Meena Seshamani, the director of Medicare, is both an ear, nose, and throat surgeon and a health economist. She joins Dr. Josh Sharfstein to talk about her agenda for Medicare, from helping individual patients to providing care at a grand scale. Let's listen.
Dr. Meena Seshamani, thank you so much for joining me on Public Health on Call to talk about Medicare.
Thank you so much for having me.
Now, you are the director of the Center for Medicare at CMS, which is an enormous responsibility. How long have you been in that role?
Yes, I have been in this role for almost 2 years. July 6th, it will be 2 years.
And before that, tell our listeners a little bit about yourself. What were you up to?
I am a physician. So I'm an otolaryngologist or an ear, nose, and throat surgeon. And I also have my PhD in health economics. And so I have spent time through my career both working in the policy sphere and also taking care of patients. So I worked in the Obama administration, where I led implementation of the Affordable Care Act in the Office of Health Reform at the Department of Health and Human Services. And most recently, I was on the leadership of MedStar Health, which is a large health system in the Maryland, DC, Virginia area, focusing on care transformation and how do we provide care in a different way to keep people healthy. I also was taking care of patients as an ear, nose, and throat physician at Georgetown.
So I think of people who are great clinicians and trained for many years and take great care of patients. And I think of people who are health policy experts, and you are in both groups, Dr. Sheshamani, and we're fortunate to have you running the Medicare program. Why would you take a job like this? It's a pretty big responsibility.
It is a very big responsibility and a huge opportunity, and that's why I wanted to come and do this work. Exactly because taking care of patients on the ground in my clinic, you see what kind of an impact you can have on people's lives and the role that the healthcare system plays in that. To give you one example, I had a woman who came in to my office with an enlarging mass on her neck, and I examined her. I was pretty sure that it was thyroid and likely cancer given the way that it was growing. And I wanted to get some imaging done, get a biopsy, likely she was going to need surgery. And she told me that her health insurance plan only covered physician office visits and prescription drugs, so that she would not be able to get the care that I was recommending. And I told her, well, it was around October. I said, in November, it's going to be open enrollment for Obamacare, for the Affordable Care Act plans that I worked on the policy side. And I said, I want you to go on DC HealthLink and I want you to enroll in an Obamacare plan so that way you can get this taken care of. And she went, enrolled in an Obamacare plan and got a biopsy. It turned out to be cancerous and she had her thyroid removed. And I think that's just one example of many of, number one, how personal this is for me, that every time we're making policy, I think about the individual person that this can really impact, and also how important it is to bring that perspective to policymaking, where we run a program that covers more than 64 million people, right? We pay out almost $1 trillion in claims each year. We work with 1 million clinicians, 6,000 hospitals. All of those numbers translate to that bedside care of one person and the difference that you can make in that person's life. And I think that's a very important perspective to bring to the work that we do on this broad scale, to make sure that everything we do really has the people that we serve at the center of the program. And that has been so rewarding and fulfilling and exciting for me in this role.
I think everyone knows someone covered by Medicare. I mean, it's probably a very unusual person who doesn't. It is such an important health insurance program. And I wonder, as you think of that responsibility for 64 million people, how do you hope to improve the program for them?
It starts with each person and thinking about how we can care better for that person and their experience in the healthcare system better. It's things like putting things in plain language so that people understand how the program works, how they can get care. And not only putting things in plain language, but putting things in plain language in the language they are comfortable with. So we're doing a lot in terms of being able to make sure that people have the information translated, really supporting culturally appropriate care, language access. So I think that's just one example of how these things play out on the ground for individual people.
What about their financial access to care? Medicare does come with different kinds of fees. Is that an area that you are thinking about?
Absolutely. I will give you two examples here. The first is, as you may know, a new drug law was passed called the Inflation Reduction Act. As part of the new drug law, starting January 1st of this year, people on Medicare can get recommended vaccines without paying anything out of pocket. Now, for anybody who has gone and gotten a shingles vaccine and has paid sometimes a few $100s for that, that is huge to remove that financial barrier so that people can stay healthy. We also implemented a cap on how much someone would have to pay on their own out of pocket for insulin. We know that insulin is life-saving for people with diabetes. I can tell you, as a physician who ran our diabetes management program, hearing from patients that they could not afford their insulin, and that was the reason that their diabetes could not be well controlled. Now, starting January 1st, thanks to the new drug law, nobody pays more than $35 a month for a covered insulin product if they're in Medicare. So again, really thinking about all of the ways in which it's hard for people to access care, to stay healthy, and what we can do to address those things.
Now, one of the ways that it can be hard to access care is if there are no physicians in an area and there are some deserts for medical services. Does that fall to you as well?
Yes, that does. As you said, Medicare is a very big program. We are responsible for graduate medical education. So where healthcare providers train, like being able to support that. And we are rolling out 200 new training slots a year over 5 years. And importantly, to your point about being able to access some clinician, we are targeting those new slots in rural and underserved areas so that we can make sure that we are getting people to those areas. So then people who have Medicare or other types of insurance healthcare needs so that they can access the care that they need. And I think one other point with all of this, Josh, is the importance of making sure that people are aware of all of these things. So the insulin, the vaccines, it's great for us to put out a policy, but if a 72-year-old grandmother with diabetes doesn't know that now the insulin can be only $35, are they going to go and get it, right? And so we really are trying to not only put forward these good policies, but make sure they come to life on the ground through our outreach. Again, it comes back to plain language, easy to navigate, where we have financial support programs like the Medicare Savings Program, doing good outreach so that we can actually get people to enroll and take advantage of these supports.
Part of that presumably is helping people understand the benefits of certain types of therapies like vaccines.
Absolutely. We partner very closely with the FDA, with the CDC, with Health Resources and Services Administration. Oftentimes, we will take their materials and distribute it through our network so that we can continue to help to provide information to doctors, to patients, to your point, so that we can really make sure that people are getting the care that they want and need.
So I want to switch a little bit from the perspective in the clinic, which you've really explained very clearly. You're trying to make things better for patients in the clinic, to the policy level, which is where your PhD is in part. Trying to rein in costs, improve overall quality outcomes for patients in Medicare. What's your agenda there?
Yeah. And again, it is all very much grounded in that individual person who needs care. One of the big initiatives that we have is changing the way that care is delivered. And what do I mean by that? I think anybody who has interacted with the healthcare system has probably experienced a time of going in, making an appointment to see a doctor where they just ask about one specific part of you, one maybe disease you have, or one injury you got, and not really taking into consideration who you are as a whole person and how different aspects of your life, of your health, all come together to determine your ultimate health and well-being. And so one of the things that we are really trying to do is change that so that people are viewed as people when they are in the healthcare system and not just as one specific disease with one specific treatment. And how we're doing that is by creating these new models of care where you have a more team-based approach. So what do I mean by that? Let's take an example of a diabetic who comes in to someone's office, to like a primary care doctor. They can talk about diet and exercise and medications. And maybe this person lives in a neighborhood that doesn't have a grocery store nearby. Or maybe they have difficulty figuring out, okay, how do I adjust my diet? And maybe they have difficulty even getting transportation to go to the pharmacy to pick up a medication or to go to the doctor's office and get care. So that primary care doctor can partner with, say, a community health worker who maybe lives in the neighborhood of that patient, to be able to say, hey, I'll come out to your house. I will look with you in your medicine cabinet, see what medications you're on. Are you able to take them? Are you not? What's your food situation? What's your transportation like? Can we help you with transportation so that you can take care of what you need? Is your housing appropriate? Do you have mold in your house that could be exacerbating some of your healthcare situations? So you see with this example how what could have been a more like very siloed, okay, someone goes into the doctor, they're like, okay, you need to take these medicines, here's a script, go fill it, to let me make sure that you can actually be healthy. And that's the fundamental of these care models that we have developed and are really have a goal to have 100% of people in Medicare in these kinds of care arrangements.
Does that imply paying for care differently? In other words, before maybe the doctors were only paid for the time they spent with the patient. And so they don't have that much time to spend with each patient. They need to see a lot of patients. Does this change that at all? Is Medicare able to use that $1 trillion to reorient the medical system to helping people stay healthy?
Absolutely. That's why the wonky term for this is alternative payment models. We are looking at, can you reward high quality care? And in particular, can you reward excellence for underserved populations and people who have traditionally fallen through the cracks? Can you say, okay, if you keep someone healthy and you enable them to live at home, you keep them out of the hospital, you keep them out of the emergency room, that not only keeps someone healthy, but it saves money overall. It means that you are spending money in a smarter way to keep them healthy. And so we will share in those savings with you. So that way you have people who work in healthcare being held accountable for the quality of care they provide and for the way that the money is being spent to make sure that it is towards better health for communities. And that is exactly how these models are created.
Let me ask you about health equity. During the pandemic, it became very clear that not everybody had the same chance, frankly, to survive COVID for many reasons, for their exposure to COVID, for the care that they were able to receive. And it became a priority item to make healthcare more fair, to make access to health more fair. How do you see your agenda lining up with that?
I would say that every single thing that we do lines up with that, where health equity is basically where we want everyone to have a fair and just opportunity to attain their optimal health, regardless of all of the various factors that can impede that. So to come back to the example with diabetes, being able to get insulin paying no more than $35 a month removes financial barriers for people that otherwise were there, preventing them from getting the care they need to have a fair and just opportunity for their optimal health. Creating these care models where there could be someone really linking arms with a person with diabetes to see, let's look at your food situation, your transportation, your medications. Again, that linking of arms, wrapping our arms around the people we care for, helps people who otherwise might have fallen through the cracks. And coming back to the example of the training positions, targeting new healthcare providers and training them in the areas that need those services the most will help ensure access to care in those areas and make sure people in those areas, by geography, rural, underserved, have a fair and just opportunity to attain their optimal health. So really, everything that we have talked about during our conversation has that theme of equity running through it. And that is very important to us, that we think about disparities and equity and the intersection of health and social needs in absolutely everything that we do.
Well, Dr. Seshamani, thank you so much for explaining your vision. There are a lot of people who depend on Medicare, and there are a lot of people whose health can improve as a result of the changes you're putting into place. It's obviously a tall order. We've covered everything from an individual notice to patients all the way through how healthcare is paid for. I know you don't do it alone. You got a lot of people working with you there at CMS, but I certainly wish you all the best in making this happen.
Thank you so much for having me. It was a great conversation.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.